everyone, and good morning from India, good evening from the US. Today, we have with us Dr. Thomas Seyfried, who is a renowned researcher. He's an American professor of biology, genetics, and biochemistry at Boston College. And he received his PhD from the University of Illinois, Urbana-Champaign in 1976. His postdoctoral fellowship studies were also in the Department of Neurology from the Yale University of School of Medicine, and he also has a master's degree from genetics. So welcome, Professor. How are you doing today?
Well, thank you very much. It's very nice to be here. And I'm sorry you have to get up so early in the morning to do this interview.
It's a pleasure for us to be speaking to a very renowned researcher such as you, and your works have inspired us to develop products around the cancer metabolism theory. So let us begin the discussion. So Sushant, over to you.
Yeah. So Professor Thomas Seyfried, if we go to a bit of statistics in India, right? So as of year 2022, which is again published by Indian Cancer Society, right? 1.46 million people developed cancer in that year, and out of that, 900,000 people, more than 900,000 people lost their lives. So the mortality rate comes to around 65%, right? And over last year or 2 years, we have seen that there are a number of early cancer detection companies coming in India, focusing on identifying copies of genes, genetic mutations or replications, and trying to develop personalized solutions in collaboration with oncologists, whether it is certain chemotherapies, radiotherapies, and a lot of these toxic therapies, right? So if you start, what is your view on, understanding the onset of cancer? Is it really an outcome of genetic mutations inherit, or probably, whatever the somatic mutations develop, or is it a lifestyle problem?
Well, we've looked into this in great detail. First of all, you should know what cancer is. It's cell division out of control, dysregulated cell growth, which can happen in any population of cells in some organ of a person's body, whether it's a breast, a colon, a bladder, a brain, a skin, wherever it could be. You have this dysregulated cell growth. The origin of cancer comes from chronic damage to the mitochondria of cells. Chronic damage leads to then a compensatory increase in an alternative energy, which is ancient energy, which we refer to as fermentation, energy without oxygen. All cancer cells that we have studied have this singular characteristics. Once this happens, the organelle called the mitochondrion, which is the most important organelle in the cytoplasm of the cell, which regulates the stable and differentiated state of the cell, gradually loses control of maintaining regulated growth, this organelle. And as it becomes corrupted in energy, it performs ROS, reactive oxygen species. The ROS cause, in large part, the mutations that we see in the nucleus. So the mutations in the nucleus are downstream effects of the damage to oxidative phosphorylation, the insufficiency. So they're not the cause of any known cancer. They are the effects of the dysregulated cell growth. And I think this can account in large part for why we're making very little, if any, progress in managing cancer, because what people think is the cause of cancer is incorrect. The theory of the somatic mutation theory has now been fairly convincingly undermined. It's no longer responsible. For those people who understand the scientific literature, who read the scientific literature, who are not cognitively impaired, can realize that cancer is not a genetic disease. it is a mitochondrial metabolic disease. Once that becomes more recognized, I think we'll start to see major drops in death rate and things like this.
Okay. Okay. And also, so these genetic mutations which generally occur as an outcome of mitochondrial dysfunction, right? Are these similarities in the same tumor, or these are entirely different within the tumor cells and probably in different tumors or intertumor?
Yeah, everything what you just said clearly. When people have looked at solid tumors or blood tumors for that matter, and you separate two individual cells and then clone them up, every cell in the tumor has different constellations of mutations. There's no commonality between one tumor and another, between cells within a tumor. They're all very, very different. And you have tremendous number. Now, there are a few mutations that seem to be more prevalent, but no, like P53 or some of these things. But no, they're not 100% present in all of the cells of the tumor. Brain has different mutations than colon, different than others. Even within this, as I said, even within the same tumor. So, which is perfectly understandable when you realize that a lot of this is epiphenomena downstream effects. What is most puzzling is the fact that there are some tumors that have no mutations. If according to the somatic mutation theory, mutations cause dysregulated cell growth, but we are now finding tumors that have dysregulated cell growth without observable mutations. And the field is having great difficulty explaining this. As a matter of fact, they don't explain it, they ignore it. We find that we have these driver mutations that were thought to be the cause of cancer. We're now finding that large numbers of driver mutations in normal tissues of our body that are not associated with dysregulated cell growth. So clearly, a focus on mutations is a waste of energy and time and has not yielded any significant drop in death rate. And as long as the fields continue to focus on mutations, we will continue to have large numbers of dead people from cancer.
Yeah. So the most of these personalized therapies are focused on those few identified mutations, and a lot of them bypass them, right?
Yeah, they don't work. I mean, they work for some people. Every now and then, the blind squirrel finds a nut, and you do get some people that respond really, really well to an immunotherapy. But many people die from the immunotherapies by attacking normal tissues that have that same epitope, and you destroy the liver and kidney of some people. Many of these immunotherapies don't work at all. But the worst ones, the ones that I think are the most concerning, are the ones that cause hyperprogressive disease, which is the immunotherapy kills you faster than the tumor you're trying to treat. So the term is hyperprogressive disease. And it happens in about 15 to 17% of tumors. People get immunotherapy and die faster than if they did not do immunotherapy. So you have to worry about all these kinds of things. Yeah, there are some people who do really well, and we're very happy that they do that. But there are so many other ways to do a much better job without toxicity, and the field seems to not recognize that.
Okay, and so Dr. Thomas, there's another thing which we are hearing in India, because I think among the top cancer, the breast cancer is the top cancer in India, right? Apart from the oral cavity, right? There are a lot of these genome companies and testing companies are talking of BRCA1, BRCA2 mutations, germline mutations, right? So and then that's a proper marketing propagation that we identify them and then we help you eliminate those mutations using various therapies. So is it correct? Is it BRCA1 could cause cancer?
Yeah, none of the germline. Now you have the somatic mutations, which we just spoke of, which happen from random wear and tear on a particular tissue. Germline mutations are what we call risk factors. They increase your risk of getting cancer. But we have now tracked down and we looked at all major germline mutations, And every one of them, in one way or another, disrupts energy metabolism in the mitochondria, leading to dysregulated cell growth. So again, the germline mutations damage oxidative phosphorylation or reduce it, causing secondary fermentation and dysregulated cell growth. No mutation germline has been found to be 100% penetrant, meaning that every person that has the mutation gets the cancer. BRCA1, BRCA2, they're about 50, 60% penetrant, meaning that 40% of women with the mutation will never develop cancer. The highest penetrant one we know of is the Li-Fraumeni, which is an inherited mutation in cytochrome C synthetase enzyme. And that's about 90% penetrant, which means that, but it's not 100% penetrant. So all of these are high risk factors, some of them moderate, some low risk factors, but all of them influence in one way or the other the mitochondria. Cancer is a mitochondrial metabolic disorder. The evidence is so overwhelming to support that. And it's surprising to me that anyone would even think something different when the evidence shows that all of these other things are either secondary or downstream effects of the real issue.
So coming back to this question earlier, and since you mentioned about that cancer is a mitochondrial metabolic disease, and the same thing which is clearly demonstrated in your book, right? Could you just share a bit of research or data or research you went through which demonstrates this, or probably which testifies this fact that it is not a genetic mutation? Probably there might be some research happening in the past which you may have referred.
Yeah, well, I mean, yeah, we have to look at a theory under which the research and the linked therapies are based. And we base in science, we base it on theories. And is the theory that people operate under correct or incorrect? For 1,800 years, the science from Aristotle to Ptolemy thought that the Earth was the center of the solar system. And massive, complicated mathematics. I think there were some folks in India also that were working on these things. The mathematics kept producing epicycles and deference and making things more and more complicated. And then Copernicus simply replaced the Earth with the sun and could then better account for the movement of the planets through the heavens. They could be predicted. There was predictability once the theory changed. Before that, it was very difficult to predict anything. So I look at the current situation in cancer as very similar to the challenge of the geocentric theory with the heliocentric theory, saying the sun is the center of the solar system, with the Earth simply being another planet along with the others that are circling around the sun. We are today confronted in the cancer field with a very similar situation. The worldview is that cancer is a genetic disease. This concept has not been effective in dropping the number of dead people from cancer, either in the United States or any country in the world. More and more people are dying from cancer today in every major country than ever before. And the treatments, the precision medicine, and all of these kinds of treatments are based on the somatic mutation theory. If the somatic mutation theory is incorrect, then we're not going to get any major advance in dropping numbers of people dying. Cancer is a mitochondrial metabolic disease. Once people realize that, we will be able to significantly drop the number of people dying from cancer, because we know, based on the mitochondrial metabolic theory, the cancer cell is trapped into using fermentation fuel. And we have interrogated cancer cells to ask, what do they use for energy? Without energy, no cell can grow. And we have found that glucose and glutamine are the two predominant fermentable fuels driving the dysregulated growth of these tumors. And because the mitochondria are inefficient, they cannot switch to fatty acids or ketone bodies. Consequently, we know how to trap and kill cancer cells with minimal toxicity. The problem that I just described to you is either ignored or incomprehensibly so complex that no other few humans on the planet can understand what I just said, or they choose to ignore it. And you have to make that decision.
Yeah. And also, I also read about you mentioned in your paper about the mitochondrial and nuclear transfer experiments, right?
Yeah.
Which also establishes the fact that the nucleus is not the origin of cancer, right? So if you could probably throw some light on that as well.
Yes. Well, of course, that always is so much more clear with the image and a diagram. But I have found from a deep research on many different animal models and different systems, both in vivo and in vitro, that if you take the nucleus of a tumor cell and separate it from the cytoplasm and place it into the cytoplasm of a normal cell with regulated growth, and then you place that under the skin of a rat, you do not get any tumor at all, despite the continued presence of the so-called somatic mutations. On the other hand, if you take the normal nucleus and put it into the cytoplasm of a tumor cell, you end up with dysregulated cell growth and tumors. And this has been substantiated with frogs and mice and a variety of in vitro and in vitro experiments, repeated many, many times in different organisms, to the same general conclusion that it is the cytoplasm and indeed the mitochondria in the cytoplasm that is largely responsible for the maintenance of the quiescent differentiated state or responsible for the dysregulated growth if those organelles become corrupted or dysfunctional. So clearly what it says is there's no uncertain. Cancer is a disorder of the mitochondria in the cell, not from the mutations in the nucleus.
Okay. So that's make it very clear that all the people are going for a wrong stuff. They're solving for wrong things. They're again managing something which is not going to help, right? So you mentioned,
and not only not help, potentially kill patients.
yeah. I've seen probably in my network, my friend's wife lost her life to breast cancer, not because of cancer, but because of the treatment, as you mentioned, right? So again, cancer was not the reason for her death, right? And that's a bigger problem. In case of my father also, every 20 days he has to go for some therapies and drugs, and again, every time they measure CA and then they look at PET scan, and again the situation doesn't improve, right? So again, yeah.
I understand what you just said, but the most amazing thing to me is how what you just described with your father is taking place all over the world, in the United States, every major country, mindlessly doing the same thing over and over again. It's almost like the entire world is hypnotized into a treatment and can't think of anything different. It's unbelievable. I've never seen anything so prophetic in my life. Why in India? When I went to visit India, I thought they would be open-minded in a way that would allow us to potentially look at different perspectives. They were in lockstep with irradiating and poisoning people with chemo and doing the same crazy stuff that we're doing at the major medical centers, cancer centers in the United States, in Germany, in England, in France, in Japan, in China, and Brazil. Everywhere they're doing the same crazy stuff and getting the same poor outcomes. Now you tell me what's wrong with this. Can you envision what is going on with the world mind when it comes to cancer?
What I think it has become a business, right? It is no longer a healthcare. I do not call it a healthcare. I generally call it a sick care, because generally we are making money out of it. I've seen, I'll tell you that's it. I don't know whether it's practiced everywhere, but what I've seen is, if you have to go and get your chemotherapy, if there's a hospital in India, in Delhi specifically, it has 70% of the patients are cancer patients there, right? 70%. And again, it's like a fish market, right? You go and you're buying stuff. It's like a vegetable market, right? And again, it's if you are paying from your own pocket, right? You're paying a 1/10 of what you'll be paying via insurance, right? And that's a typical practice because that's how hospitals make money. That's how all these drug companies make money. And again, it's not about cure because there isn't program thing in the mind of the oncologist that this is a genetic mutation and we have to kill those mutations. We have to resort to these harmful chemicals and toxins to kill those, and that's a normal practice people have developed. And if we have to educate on that this is not a genetic disease, it's a metabolic disease. It's caused by dysfunction in your mitochondria, which can be caused by a lot of factors including inflammation, oxidative stress, or maybe exposure to carcinogens, right? So essentially people do not believe it, or they are, because a lot of businesses are run on these basis, and a lot of businesses are funded on these
So yeah,
basis.
yeah. So now we're away from biology
Yeah,
and we're talking about business.
yeah,
So cancer is a business. It's not whether or not the patient gets healthy. It's whether how long you can make money on this poor sick person before they die.
yeah.
So this is a worldwide immoral behavior on the part of the medical establishment. If what you said was correct, that the purpose of treating cancer patients is not to cure them, but to make money on their sickness, regardless of where that happens to be, whatever country it is. Because I think I don't want to say 100% correct, but I think you are on the right path about this. So we have to decide as a species of human, what do we choose to value more, the almighty dollar or the soul of an individual? And that's a different series of questions. But according to what you mentioned to me, and I've heard it many other times from others, it seems like the immunotherapies and all these things are wonderful because they can generate tremendous revenue, whether or not they happen to have a major therapeutic benefit. And if you can get it on a few people, then they say, oh, look how wonderful this one person or few people survived. But all these others were put to death or harmed significantly as the result of this. And you are 100% correct. If cancer is recognized as a mitochondrial metabolic disease, which we now know how to prevent effectively, and we now know how to cure effectively, who will find a way to make money on this? Because if you can't make money, the therapy that will be the best effect on people cannot be used because we cannot make money. Therefore, the money becomes more important than the person's existence or soul. So we have to separate these kinds of things
Yeah.
and make sure that people know about this.
I'm telling you because we actually experienced this firsthand when my father was going for these therapies. The oncologist told that, if you have to survive, you have to come every 21 days and get these drugs, right? So that's a kind of fear being created. Obviously, the objective is to extract a lot of revenue from the patient, right? So that is something which is really really concerning, right? And it's everywhere. It's not only in India, right?
Oh, it's
So
everywhere.
yeah, so Dr. Seyfried, there is another thing which I want to discuss on the fermentation aspect, which you mentioned about glucose and glutamine, right? So essentially, this generally means that if we starve ourselves of these fuels, the both the healthy cells and the dysfunctional cells, right? It could be one of the way to delay the onslaught of cancer, or probably manage the cancer effectively, right? But glucose is what we understand. We can easily, it's something we can replace it with other fuel sources. But could you shed some light on glutamine, right? Because glutamine again is produced inside our body indigenously, right? And again, it's need for various biochemical functions. So how do we actually make sure that we are not feeding the cells with glutamine?
Yeah, well, this is a very important question. And people ask me all the time, what can I eat or not eat to reduce glutamine? The answer is you can't do that. It's not, just like you said, glutamine is produced in the body. It's a very important amino acid for the health of our gut, for the health of our immune system, and for urea cycles. I mean, you cannot eliminate glutamine like you can glucose. Glucose is easy. It's a non-essential metabolite for the majority of things. Only erythrocytes in our bloodstream need glucose, and they need very tiny amounts of this. So you have this. But we developed the press pulse therapeutic strategy, which we published open access, which shows that you chronically restrict the availability of glucose by using the glucose ketone index calculator, which is a ratio of the millimolar of glucose to the millimolar of ketone in the bloodstream. Because don't forget, normal cells of the brain and other organs can easily transition to ketone bodies and fatty acids for energy, but the tumor cells cannot do that because you need a good mitochondria to do that. But that leaves the glutamine availability, even if you are successful. So that's why we know that there are certain drugs, repurposed drugs available that have been used in the past, like deoxynorlucine, DON. There's some others that can be used. They can target glutamine, but you must be very cautious in how you target glutamine for the very reasons that you mentioned. You don't want to cause abnormalities in the microbiome. You do not want to cause abnormalities in the urea cycle. You do not want to paralyze your immune system. So you have to be very strategic in how you target glutamine. So we can press down glucose, but then we strategically, in a short burst of treatment followed by removal of treatment, we can then kill large numbers of cells once their glucose and glutamine are simultaneously targeted together. But if we kill a large number of cells, our immune system must come in and pick up the dead bodies, the corpses of the dead cells. So we need the immune system, which uses glutamine very avidly to remove dead corpses from inside tissues. So if we just pulse the glutamine, we kill tumor cells, but we paralyze the immune system. But if we take the drug off, allow the immune system to recover, to pick up the dead bodies, but the immune system isn't killed, it's just paralyzed. So you have to be very cautious. This is how we strategize, how we can slowly degrade the tumor by choking glucose and pulsing glutamine. And eventually, the tumor will become more managed. And then, at that point, if the tumor is still there and very indolent, slow growing, less angry, less inflamed, we could come in with a number of parts of the standard of care, even immunotherapies, maybe some small amount of radiation, small amount of chemo, and finish off any of the survivors. So again, reducing the toxicity of the patient, but maximizing the therapeutic strategy for degrading these tumors while protecting and maintaining the health of the normal cells of the body. It's unbelievable. This is so elegant, so beautiful. The problem is that it requires an understanding of evolutionary biology and systems biology, biochemistry, and all of these other things together. But this will become the standard of care worldwide once oncologists and the patients themselves come to understand this.
Okay. Okay. And apart from that, there's any other amino acids which cancer cells ferment?
We tested that. And we looked at all 20 amino acids. We interrogated and asked whether any other amino acids could be as effective in replacing glutamine. And the answer is no. Glutamate can do a little bit, but glutamate is derived from glutamine. So if you block glutamine, you're not going to get too much glutamate. Asparagine, the other thing is you have to realize if you have a cell with inefficient energy production, because it's so inefficient, the way you make up, you have to have a large quantity of fuel in the microenvironment because a normal cell doesn't require much fuel. It's so highly efficient. But the inefficient cell requires significant logistic supply of fuel. The biggest amounts of fuel is glucose and glutamine in our body. very little asparagine, very little other amino acids. So if they are there, some cancer cells can use them. But the problem is there's so little of it, it's not sufficient to maintain dysregulated cell growth. Glutamine and glucose are the only two major fuels that are responsible and can maintain dysregulated growth. So that tells you right there. So when you go around the world and ask people how are they treating cancer, is anyone targeting glucose and glutamine simultaneously? And the answer is no. And why is that? Because they think it's a genetic disease. If you think the theory is wrong, you never think of the correct way to treat the disease. Unbelievable.
Yeah, so that is something, that's what I've been reading your book, and that's how I figured out that press pulse is one of the therapeutic approach which can be combined with the standard of care which is currently in practice, right? But there's important thing I want to understand is that there would be certain cancer cells that may relying only on glutamine, right? Not on glucose, or there will be some on glucose, not on glutamine. There will be some doing on both. In that case, if there are cancer cells who are relying just on glutamine, would they be apparently tracked when people go for PET scans?
Yeah, well, you might not see some of the, yeah, that's right. Well, in our mitochondrial metabolic therapy, press pulse therapy, we don't discriminate. We target both fuels together. So we don't care whether you're glutamine dependent or glucose dependent or some in between. Yeah, so I mean, but you can use PET scan, MRI, CAT scan. You can use a number of different methodologies to look and to see if you have a tumor. The issue is when you have a tumor, you can see it with these various non-invasive technologies. And even PET, yeah, you can put fluorodeoxyglucose and it lights up. And some tumors don't light up, maybe more glutamine dependent, but you can see them on other non-invasive ways to do this. The question is when you simultaneously target the two metabolic fuels while transitioning the body over to nutritional ketosis, and then you target with maybe a small dose of a standard of care, and the tumor disappears completely, and you can't see it, what are you supposed to say? And then you ask the patient, how do you feel? That's the most important question you can ask a cancer patient. How do you feel? Oh, I feel great. We can't, is my tumor still there? Sometimes the tumor is still there, but it becomes indolent. It becomes very non-aggressive. I have worked with people who have had brain tumor that lasted 10 years, never cured, but never killing the patient. So, and we've seen this now in breast and colon and a variety of other cancers. They're there sometimes, but they become like very mild, very non-malignant, very indolent, from a very angry state to a very less angry state. And there's where we can come in and possibly destroy or get rid of them slowly. So we're going to see all this. All of this I have already seen in people that I have talked to and looked at. It's just that we have not done any major clinical trials to prove what I'm saying, mainly because no one knows what the hell I'm saying. When you talk to oncologists, they never heard of this. They get angry about it. Patients get frustrated. And who knows how to do a clinical trial? We publish the procedures. We just measure all these. So people with any level of medical understanding and a degree to practice medicine should be able to do it with a little training. But right now, like you said, they're hunting for gene mutations and doing all this crazy stuff that's largely irrelevant to the nature of the problem. So you're stuck in this problem zone.
Yeah. So regarding this nutritional ketosis, and one of the most important aspect I want to discuss is when we know that for sure that glucose and glutamine are the two fuels which feed cancer cells, and again, even if we prevent them, these cancer cells do eat up all the things which is there inside your body, even your muscles, right? And there's a lot of muscle wasting and a lot of these things. So still, I've seen doctors telling to eat a lot to increase the intake, appetite, right? Maybe giving certain steroids, right? In terms of increasing the appetite so that they gain weight, because they generally calcium absorption lose weight, right? So what is the mechanism, and how does this impact the entire survival mechanism of the patient?
Yeah, well, that's called weight loss from cachexia. It's a pathological weight loss. The tumor cells start devouring or causing muscle to disintegrate, and muscle proteins amino are broken down into amino acids, which will go to the liver, make gluconeogenesis, and you can get direct glutamine out of some of these muscles as well. The issue, of course, is cancer cachexia from metastasis, from metastatic cancer. We have defined the nature of the cell for metastatic cancer. It's a macrophage. We know that all major metastatic cancers share the biological patterns of a mesenchymal myeloid cell, which is the macrophage. So once you know what the origin, it took me 12 years to find what the origin of the metastatic cancer cells happen to be, and it turns out to be a macrophage. All major metastatic human cancers have characteristics of macrophages, whether they got it from a transformation of a normal macrophage. Most of it comes from fusion hybridization between the immune system and cancer stem cells. Cancer stem cells cannot metastasize. They grow very, very rapidly in place with a lot of angiogenesis and inflammation, but they don't spread around your body. When the immune system attacks this stem cell growth, they fuse with the stem cells, and our immune cells then become contaminated. Our own immune cells have weakened mitochondria. They start to ferment, and we have found out that the main fuel driving macrophages is the amino acid glutamine. So we now know that glutamine is the main driver of metastatic cancer. Whether or not they use glucose, they need glutamine. So again, in order to make more cancer cells, you need glucose carbons. So glucose carbons are needed for fatty acids and nucleic acid synthesis. Glutamine carbons are needed for proteins and nucleic acid synthesis and energy. So these are the two fuels driving all this stuff. All of this stuff is driven by these two fuels. And let me ask you this, why nobody's targeting these two fuels? Why nobody is transitioning their patients to nutritional ketosis and simultaneously targeting the two major fuels driving dysregulated growth? Do you have an answer for this? Can you tell me why nobody's doing this?
That what I feel would be two major reasons. One, they do not know because they do not read, right? Yeah,
Well, that's a
yeah,
terrible thing to say. You're
yeah.
bringing your precious soul into an oncologist who doesn't read.
Because because what I feel earlier the doctor or this profession was a noble one, was there to service people, to help people. Now it has been transformed into a business, as we earlier discussed, right? So essentially it's a both reason. One is they do not want to read, they do not know, and they do not want to learn. Second is obviously they want to continue with the current status quo of running the genome and addressing the
I simply have
mutation.
another opinion here. Maybe they just want to play safe. They just don't want to take the accountability of curing the patients. They don't want themselves to be held accountable for anything. They just want to go around and work on the traditional therapies so that, they can say, okay, this is, clinically relevant. There are clinical trials to prove it. I mean, though we don't know that whatever data they are presenting, even if it is authentic or not. I mean, we know that there is some data around.
Yeah, well, the other
So
thing too is that the system itself, even if you have a physician or an oncologist who really, really wants to help and cure his patients, the system doesn't allow it. If he tries to go outside the standard of care, he may lose his license for doing this. So there is some force suppressing curiosity and flexibility in the way we treat cancer patients. I don't think all these oncologists are just interested in business. I think many of them are, for sure. But I don't think they all are. And I know I have friends in India who are treating patients with metabolic therapy. And they want to see the health of their patient improved. I think that's why you go into this profession. But I think the system prevents this, and the attractiveness of the money, together with the rigidity of the system, not allowing flexibility. So you put all that together, and you have this worldwide cancer crisis. which doesn't seem to go away, but only gets worse and worse. And nobody is treating the treatments that we are proposing based on hard scientific evidence that we have published over and over again in all of these different systems. And we publish case reports on humans showing if you do metabolic therapy with parts of the standard of care, you can achieve a much greater survivability than is currently being done. And yet we have this worldwide lack of knowledge, or you want to say don't want to read, driven by the business model. So you have all of these different things impacting together to prevent reducing death from cancer.
I'll add another thing what Sakshi mentioned. Dr. Seyfried, what we have seen is there are a couple of new companies coming up that focusing on developing immunotherapies for specific protein and specific genes expression, right? Again, that goes back to the same theory of somatic mutation again, because there's a lot of money being poured into such researches. Again, even metastatic cancer, which accounts for 90% of the deaths, right? Again, the focus is on developing those models without understanding, as you mentioned, about the macrophages, the role of macrophages in causing this spread of cancer to different parts of the body, right? So again.
Yeah, I think I think you have to start to ask all these members of new companies who want to get into this cancer business, is your company and the products of your company based on the somatic mutation theory or the mitochondrial metabolic theory? That's what right off the yeah.
So we do not believe in DNA. We do not believe that DNA for 90% of the cases may cause any diseases because DNAs are static, right? Again, our focus is from even cancer perspective, our focus is more on understanding what specific factors are impacting the mitochondria, right? Whether it is inflammation from your mouth, from your gut, whether it is oxidative stress, whether it is certain other, industrialized factors and other carcinogens, which is there, maybe air pollution, number of things, right? So essentially, we do not believe that somatic mutation or the genetic mutations are the cause of cancer as here. So we generally align with your theory of what you have been, educating the world right now, right? So that's our focus on cancer as specifically, and that's why we are receiving a lot of questions on this, a lot of provocative discussions on cancer in terms of you don't. So people are saying that you do not read related literature, you do not know basics, and there's a lot of these things, and these are typically in India that people are very, very aggressive on these things, right? That's a lot of things what we happen, right? And again. So as you rightly said, because mitochondria is actually, it controls your cell growth. So essentially, it is in fact science fact. You don't need to prove that mitochondria controls the cell growth or not, right? And then that really goes into understanding that it is linked to somewhere in mitochondria, not linked to some P53 mutations, some BRCA1 mutations in your DNA, right?
Yeah,
In your nucleus,
I
right?
think that's that when that comes to when people come to know about these things, and not only does it work on cancer, it's also associated with Alzheimer's disease, type 2 diabetes. All these chronic diseases are the result in one way or another of compromised mitochondrial function. The nice thing about a metabolic therapy is it not only can be used as a treatment for cancer, but with modifications, you can use it to prevent cancer. Because if cancer is the result of chronic damage to mitochondria, and you prevent chronic damage to mitochondria with diet and lifestyle issues, then you can significantly reduce your risk for cancer. The problem is our environments, whether in India or the United States or anywhere, is being saturated with forever chemicals and microplastics and type 2 diabetes, systemic inflammation. All of these things together impact negatively on populations of cells in different organs. And sometimes you would get diabetic, sometimes you would get cardiovascular, other times you get cancer, hypertension, high blood. You can go through the whole list of chronic diseases. And all of us, it's diet and lifestyle. The primitive peoples, I don't know in India, but in some African and Australian areas, the Aboriginal folks who live according to their traditional ways is very rare to get cancer. It's only when the Western diet and lifestyle enter into your society do you end up with obesity, hypertension, high blood pressure, cancer, and all these chronic diseases. But that's the choice people have to make. But I don't think once you are educated to know about this, maybe you can modify a little bit. But when you have a worldwide obesity epidemic, nobody seems to care. Well, obesity is replacing smoking now as the number one risk factor for cancer. Well, if that were true, why are all these fat people walking around? You should never see a fat person, or very rare, right? I mean, so nobody seems to care. So you can talk all you want. All they want to know is, when I get cancer, what are you going to do for me?
Yeah. So one aspect I want to discuss, probably, you could shed some light on this, and I have been also doing research on this aspect. So we have seen we were working with certain trying to collaborate with certain hospitals who are also using hyperbaric oxygen, right, as one of the additional therapy apart from the standard of care, right? And again, uh, probably could you shed some light on that? And also, does the indigenous production of nitric oxide inside our body, right, could help in some sort of reducing the hypoxia environment?
Yeah, well, first of all, hyperbaric oxygen, my friend Dominic D'Agostino, world expert on hyperbaric oxygen utilization, we found in our research that when you put patient in hyperbaric oxygen, you actually dissolve oxygen into the liquid itself. If you take oxygen by the mask, you will saturate the hemoglobin in all of the cells of your body sufficiently, but you do not dissolve oxygen into the liquid. You need to do that under pressure. If you have a cancer patient and that patient is on ketogenic metabolic therapy, where blood sugar is reduced and ketones are elevated, they now are much more vulnerable to oxidative stress because their antioxidant system that is built by the carbons of glucose and the carbons of the glutamine are no longer there for glutathione production or pentose phosphate pathway production. So now your tumor cells, they already have a lot of reactive oxygen species, but they have an antioxidant system that just keeps them under the death lay. You put that patient now, while in nutritional ketosis, low glucose, elevated ketones, and now put under hyperbaric oxygen. The hyperbaric oxygen could cause the radical damage in the tumor cells and not in the normal cells because they're protected from ketone bodies. So there is a way to kill tumor cells more effectively. You can do that with IV vitamin C as well. IV vitamin C will increase reactive oxygen, but it works a hell of a lot better when the patient is in nutritional ketosis than if not in nutritional ketosis. So you can see how to utilize all of these different tools that we have available. And when used in the correct way, they can be extremely powerful in managing cancer without toxicity. So clearly, it's the knowledge of the physician to know what tools they have and what is the best strategy for using the tools that we already have.
So for HBOT, probably we should first be in nutritional ketosis to make sure that ketones are protecting the healthy cells, and and also the cancer cells are not producing lactic acid and succinic acid to protect their microenvironment. So essentially, both should go hand in hand, right?
That definitely go hand in hand, and that's one of the things that immunotherapies and radiation and chemo, they're always confronted with the wall of acidification around the tumor. Well, the wall of acidification is coming from the waste products of glucose and glutamine, as we and others have shown. So if you can reduce the waste products of fermentation, you now make these tumor cells extremely vulnerable to all kinds of other therapies used at much lower dosages and much less time. I mean, this cancer thing can be so well managed. It's unbelievable. It's not a complicated disease. It's remarkably simple driven by fermentation metabolism and inability to use oxidative phosphorylation effectively. Yeah, the problem is that when you are brainwashed to think it's a genetic disease, something different, you're unable to even comprehend what I'm saying.
Yeah, yeah, I agree. I agree to this extent. And so one of the most important aspect which I want to discuss is that from the standard of care therapies perspective, right? Since you mentioned about, I read of your paper about inflammatory oncotaxis, right? Where which actually could directly impact, convert into malignant tumor. So could you shed some light on that? Because that is something which a lot of oncologists here do not understand.
Yeah, well, this comes from mostly from the biopsy tissue that they take from the cancer patient. I work with a number of oncologists who have shared with me, and we've looked over many, many papers: breast cancer, colon cancer, bladder cancer, brain cancer. When you do a biopsy, you damage the local microenvironment of the tissue. You make it inflamed. So the immune system comes rushing in to this damaged tissue from the signals that it releases, leading to the possibility that those immune cells will fuse with the stem cells in the microenvironment, leading to a metastatic spread. Also, why, when you take a biopsy, there's at least two major reasons. Number one, they like to look at the architecture of the cells to determine whether or not this is a grade 1, grade 0, 1, 2, 3, 4, whatever it is. Number one. And then they take these tissues and they do genetic analysis of the tissue to tell you what kind of mutations that you might have in this tissue. And why this is so ambiguous is because after you take the tissue with a biopsy, you have changed the microenvironment, so the expression of different epitopes has already changed, and you have potentially put that person at risk for spreading the cancer around the body just to get information. Oh, you have a low grade, but after sticking it, now you have metastatic cancer. And then they will say, we'll spend a lot of money looking at the genetic profile so we can determine what mutations you have, which are largely irrelevant. So why are you putting a patient at harm's way by getting largely irrelevant or non-consequential information? And this is another a very difficult fact and knowledge to swallow on the part of the oncology community. No, you have so many ways to look at non-invasive imaging. Who cares whether it's an indolent or not? Once you see it, the job is to eliminate it without disturbing its microenvironment. And we can do that. We can put patients on metabolic therapy. If it goes away completely, then you didn't need to stick it. If it shrinks down and becomes small, then the surgeon can come in and remove it completely without doing any biopsy. Just get rid of it. So the ways, I just find it fascinating that we have so many ways to manage cancer in a logical way based on the science and our understanding. Inflammatory oncotaxis is the inflammation from the stabbing of the tissue spreading the cells around the body, which they say, well, it doesn't happen very often. Well, even if it happens 1 out of 1,000 times, you're killing these poor people that don't have to die. So what are you doing? This was the reason for Johnson & Johnson having to remove their morcellation procedure for uterine polyps on women. They have kind of a lawnmower machine chopping up the polyps on the woman's uterus. And some of those were inflammatory oncotaxis led to the spread of cancer all around the body. To a significant number of women where Johnson & Johnson had to discontinue the use of the morcellation procedure because they didn't know why. I says it's because of inflammatory oncotaxis. That's why. They had no clue about the biology of the disease they're working with. And when you have people that lack knowledge on biology, sometimes you can get outcomes that are catastrophic and tragic.
No, this is something which has to be addressed because a lot of lesions which may be converted into a very aggressive form of cancer if this oncologic toxicity happens, right?
Yeah.
So that is great, Dr. Seyfried. So what our request is probably if we could get into another discussion maybe in next few weeks down the line or next month sort of, because I was thinking if we could discuss on one specific cancer in terms of how you can address. Probably since you have worked on the brain cancer, that could be a good option to talk, especially on the brain cancer. And we would also discuss about how the standard of care could, in fact, lead to more aggressive form of cancer and lead to even mortality. Maybe.
Isn't that terrible what you just said? How the standard of care for treating it makes it much worse and ends up killing the patient. It's just so tragic on every level. I don't care what country you live in, what
Mhm.
nationality, what
Mhm.
religion you have. It doesn't make any difference. I mean, these things are tragic for the humankind, and it just stands to a lack of knowledge and a failure to be more open-minded about these processes. We just published a major paper on treating brain cancer
Mhm.
in BMC Medicine with my colleague, Dr. Thomas N from Spain and the Czech Republic. And he has done a magnificent job in fleshing out press pulse metabolic therapy. People should use this and see what the response is. So yes, we have, but I would recommend speaking to Dr. Dorai
Okay,
about the brain cancer.
sure.
He wrote the complete how-to manual to manage brain
Mhm.
cancer without toxicity,
Mhm.
and we do not recommend radiation therapy for brain tumors. It only makes it
Mhm.
worse.
Yeah,
So,
yeah.
yeah, no, so we can talk, but I think he's the one. He has such
Okay.
detailed knowledge.
So probably what we can do is probably I'll write to you separately on this. We could invite you both on this discussion, maybe on at a time convenient for you, right? We can
Yeah,
discuss
well,
this, right?
we know what you want to do. You want to
Mhm.
go out with all the information that I just gave you and share it with oncologists and
Yeah,
see how their response is.
yeah.
And you will come to know right away what the problems
Hmm.
are.
Yeah, yeah. And also another thing I wanted to ask, so in terms of the metabolic therapy, the pulse therapy, right? So there should be an order of doing this. Probably we should start with this and then we go for the standard of care. So
Yeah,
is how does we
that's what I,
structure it?
yeah, I would think metabolic therapy up front, shrink the
Mhm.
tumor down, make it less aggressive, less angry. And
Mhm.
then if it doesn't go away completely, you always have options to use small reduced doses of standard of care, whether it's a radiation, or surgery for sure, radiation, chemo, low dose chemo, and
Mhm.
immunotherapies. So all of those are on the table. All of those can be utilized for finishing off the surviving tumor cells. But you should do it once the tumor is in extremely vulnerable and weakened state from metabolic therapy. And then
Sure,
potentially you can get a cure, potentially.
sure, sure. So thanks, Dr. Seyfried, for your time. I think we have taken a lot of your time on this, right? And for all my listeners, I want to say that, I bought this book written by Dr. Thomas Seyfried, and it is really, really knowledgeable. I have not read completely. I've just started off. I've read 3 chapters here, and then again, this is a go-to Bible if you really want to understand the progression of cancer. It is backed by the research which Dr. Seyfried had done, and I will recommend everyone to buy this. Right? Dr. Seyfried, thank you again. And we would like to invite you shortly. We'll send you an email on whenever we can have a next round of discussion, next round of call on brain cancer, where we could invite other doctor who have been working with you also, right? And
Yeah.
it was great to have spoken with you. Great to hear your insights, and I'm sure this will really help people who are actually suffering from this disease, right? And I know because my father is also of your age, right? And again, he would probably will he's sometimes he doesn't listen to me on all this, right? So again, he may believe now that someone is from the scientific community is talking about this, which I've been always pushing him to, please adopt this. Do not blindly follow your doctor. Understand this, understand hyperbaric oxygen and a lot of these things. So probably that will really, really help. And thanks a
Yeah.
lot.
Okay. Thank you.
Thank you. Bye
Okay.
bye.
Goodbye
Have a
now.
great day. Bye.
Thank you. You too.